Very good evening to all. Myself, Duna. I welcome you all for this webinar session, and I would request Dr. Chandramohan sir to greet everyone.
Greetings, everyone. This is Dr. Chandramohan, musculoskeletal and sports physiotherapist and founder of Exercise Testing and Prescription Organization. I'm so excited to welcome you all to this webinar after a long time. We have 850 registered participants from 10 countries: Kuwait, Egypt, Rwanda, Philippines, Nigeria, Bangladesh, United Arab Emirates, Malaysia, United Kingdom, and almost all states of our nation, India. We are honored to have such a diverse group of participants from all over the world. And this is a great opportunity for us to learn from each other and share our knowledge. The majority of participants were BPT and MPT students. There were 98 BPT students and 118 MPT students, respectively, and others are 33 PhD scholars, 91 faculties, and 256 clinical practitioners and freelancers, 56. I would like to thank you all for the register speakers for taking the time to share their expertise with us. We will be hearing from Dr. Sedhunivas, who is an assistant professor in a private university in Bengaluru, and he is a cardiovascular physiotherapist. We will be discussing the topic of an emerging hidden disease in almost all, and our speaker will reveal what topic he is going to discuss in this. And I encourage you all to participate in the question and answer session at the end of the webinar. We will be taking questions from the audience, so please feel free to ask anything that are curious about. You can write the queries in the YouTube comment section, or we will be sharing a Zoom link in the group at the end of this lecture, and you can join in Zoom meeting and discuss the queries. Thank you again for joining us today. I hope you enjoy the webinar, and I welcome our speaker, Dr. Sedhunivas. So over to you, sir.
Good evening, all. Thank you, Dr. Chandramohan, for providing me this opportunity through your ExRxIndia platform. And I all thankful to my faculties who have taught me in good manner so that I get the most knowledge, and I'll be happy to share my knowledge and my experiences. And I would like to thank all the other supporting members of ExRxIndia. And I'm going to start. Today's topic of discussion is about emerging hidden disease in almost all. So first of all, before I start, so the question was asked in the Google form. So what was the topic about? So many guesses were almost correct, I would say, because I got answers such as sarcopenia, obesity, fitness training, exercise training, everything got the answers. But only one answer I got was the correct answer, and exact answer, which is I'm going to take about. And so that is Dr. E. Shiba, and she is a physiotherapist. And so I would like to congratulate her for guessing the correct topic. So it's a topic about the visceral organ, and so why the caption was given as emerging hidden disease in almost all. So I would say that it is a disease. It is emerging in a young population, and it's an almost a hidden disease. Why? Because it is not noticed until we are going to do a mastral checkup, or until we are going to do a scan, which is done in a routine mastral checkup, and which is going to reveal the diagnosis. And I would say that is an almost all, because today more population is going towards the junk food, so they are accumulating more and more of saturated fats, and we are having a fat which is going to be a notorious one. Why I'm calling it as a notorious is wherever it's going to accumulate, we are going to call it by a different names. For example, if it's going to accumulate, the fat is going to accumulate in your cerebral arteries, we are going to call it as a cerebral vascular disease. So the consequence is going to be a stroke. Wherever it's going to accumulate in your peripheral arteries, so we are going to call it as a peripheral artery disease. Yes, so it is going to accumulate in your coronary arteries, we are going to call it as your coronary artery disease. But what we are going to call if an fat is going to accumulate in your organs, vessel organs mainly, so then we are calling call it as a some other disease. I'm going to reveal the disease in another few seconds. And if the fat is going to accumulate in your adipose tissue under your skin, we are going to call it as your obesity. As you know, we are having two types of obesity, and here it's a central obesity, and we are having a peripheral obesity. Okay. So today's topic is about this particular organ. So before going into this organ, I would like to say some few anatomy and few facts about this organ. So we are having the liver organ. So try to appreciate these two organs, and based on the size, based on the color, texture, comparing these organs, you can appreciate. And we are having a falciform ligament, and we are having a left lobe, we are having a right lobe. So this liver organ is going to be a very solid organ and is going to be reddish brown in color. So why it's reddish brown in color? Why? Because it's rich nutrient supply, gets rich blood supply from the arteries, from the aorta, so about 1.5 liter per minute, and it's going to be metabolic organ as well. Yes, so I hope you would have appreciated this organ and this organ, the color difference, everything. Yes, so what you can see here is the reddish brown is getting lost, as well as we are having the yellowish appearance. So I would give you an example of a steel. If you take a steel rod, or if you take an iron rod, the new iron rod, how it looks.
Excuse me, sir.
Yes, sir.
Sorry for disturbance. Would you like to share the screen?
Okay.
Also speak a little bit louder, sir.
Okay. So can you see this? Can you see this organ?
Kindly go. Yes, sir.
Yes, sir. Can you see this organ, which is going to be in a falciform ligament, which is going to have a left lobe and have a right lobe? So you can see the yellowish discoloration. We can see a reddish discoloration as well here. So I'm going to relate it to a rust. So which is going to be present on a steel. So this rust is going to present on the particular steel rod, and it's going to deteriorate its function. It's going to deteriorate your strength. It's going to deteriorate your deteriorate the strength function of the particular rod. Same thing, it happens in this particular organ as well. So as the fat is getting accumulated within this particular organ, so we are having the particular disease known as non-alcoholic fatty liver disease. So this is the topic of today's discussion. We are having non-alcoholic fatty liver disease. Okay. So these are the expected learning outcomes. So we are having liver as a basic info, and what is NAFLD in basic terms. And we are having a definition which is given by World Gastroenterology Organization. And we are having NAFLD, why it's called a hidden disease. Then we are having recent trends in food and physical activity, etiology, epidemiology, so how far it's present in the population, pathophysiology, NAFLD. We are going to see the difference between NAFLD and your obesity, and we are going to see the difference between the NAFLD and AFLD. AFLD is alcoholic fatty liver disease. So next is stages of NAFLD and its progress, signs and symptoms, diagnosis, prognosis, complications, medical intervention in NAFLD, and physiotherapy evaluation and testing in NAFLD as a short form.
Sorry to disturb you. Please be a little bit louder, sir.
Okay, sir. So this is exercise protocol in NAFLD as well. Just a minute, sir. Okay. So I hope I'm louder enough. And so moving on to liver basic info. So what is the liver? It's the largest organ in the body, present in the abdominal cavity in your right upper quadrant. So it's exactly present in your below your right hemidiaphragm. So it's going to present in your right upper quadrant as well. And its color is reddish brown in color, of blood flow of 1.5 liter per minute. So the basic function is going to provide the filtration of the blood, mainly filtering the toxic materials and neutralizing the toxic materials. And we are having the rich blood supply in the form of arteries, hepatic arteries. So next is weight is about 1300 to 1600 gram. It's secreted bile as well as it's known as the metabolic factory of the body, where various chemical reaction takes place. So whatever the medications we are taking in, so it's going to be breakdown. So it's going to be released in the amounts wherever the body requirements. That is here. So we are calling it as metabolic factory. So it also secretes some hormones. So ALP or alkaline phosphatase, other hormones, which is going to enhance the functions. And it is the only organ which can go on other body after being transplanted within few weeks. For example, you transplant a nerve, it doesn't grow. You transplant an artery, vein doesn't grow. You transplant a kidney. So whatever the donor transplants, the donor's kidney doesn't grow, and for the donor also the kidney doesn't grow on its own. But this is the organ which can grow. So where, for example, if I donate a liver, part of my liver, so I also can grow on my body, and the person who is going to receive, the recipient is also can grow the liver. So whoever is having a liver failure and the person is going to donate a part of a liver, so they can also grow within the body. Okay. So what is NAFLD? So it's a non-alcoholic fatty liver disease. So what is this? It's a broad spectrum. So we cannot call it as a single disease. It's a very broad spectrum such that, so it's going to hold many subcomponent of diseases. It's going to process through various stages of the diseases. And as general population, it is going to present only in a particular form of a disease. We are calling it as a NAFLD. So when it progresses to a group of population where they are going to have a inflammation processes, we are going to call it as a NASH, that is non-alcoholic steatohepatitis. So non-alcoholic fatty liver disease is a broad spectrum of disease which is due to fat deposition on the surface of the liver, which is left untreated, eventually might lead to a liver failure. So if we are not going to treat and it's going to progress to the stages, non-alcoholic fatty liver disease, it's going to go for an inflammation stage. So always remember, whenever there is an inflammation stage, it's going to be your irreversible stage, and it's going to be
sorry to disturb you. Can you remove the headset and speak? Maybe okay. The headset is barrier for your voice.
Okay. Can you hear me, sir?
Yes, it's louder, sir.
Yeah, okay, sir. Sorry. So if going to have a fat deposition on the surface of the liver, and it's going to have a liver failure. So if you are going to untreat and is going to be diagnosed at the later stages, automatically you are going to end up in your liver failure only. Okay. So its condition arises when triglycerides content within the hepatocytes exceeds 5% of liver weight. So generally your liver contains some amount of fat in form of triglycerides, in form of LDL, HDL, everything. But when the increasing content of triglycerides increases, then what happens is, so we are going to have a fatty liver disease. So this is a definition given by World Gastroenterology Organization. So it's a non-alcoholic fatty liver disease as well as steatohepatitis. So it is a condition defined by excessive fat accumulation in form of triglycerides in the liver. So as you can see in this picture, so it's a normal liver hepatocytes, we call it as a hepatocyte, and this is a fatty liver hepatocytes. So as you can see, the normal cells along with the fatty cells. So as you see here, the fatty cells are normal hepatocytes are replaced by your fatty cells. Why? Because so this is like a fight response. So your fat is getting accumulated, deposited on the liver. So what happens? The hepatocytes tries to fight. That is your inflammatory response. So till one period of time it can fight. Then what happens? These cells die. Hepatocytes die. Wherever the hepatocytes, the fat accumulation enters, those cells die. And what happens? These cells try to go on a scarring, and we are going to have the fibrosis. So the later stages, we are calling it as a fibrosis, and we are calling it as the cirrhosis of the liver. Okay. So why we are calling it as a hidden disease? So we are calling it as a hidden disease. Why? Because it comprises many stages and goes to a liver failure, and there are no signs and symptoms. So this is the most important point I would like to emphasize. So we're having no signs and symptoms in simple fatty liver. Suppose if I'm having a simple fatty liver, I'm consuming more amount of fatty diet. So there are no signs and symptoms because there is no inflammation stages. So the next stage, in the next stage, when it happens, then we are going to the next stage. We are going to notice some signs like abdominal pain. We are going to have the loss of appetite, indigestion. So all these are going to be your signs and symptoms. So, and it is mostly replaced, noticed during your regular master health checkup scans, and condition manifest with symptom and sign when inflammatory progresses. So, for example, if you're going to take generally population trends to take master health checkup scans during the ages during 40 and 50 and above. So, for if the person is going to eat a fatty diet from starting from age 20 or from the childhood, what happens? The slowly the fatty buildup in the liver happens. Then we are going to progress. When the patient is going to take up a master scans at the age of 50 or whenever it's needed, they are going to take up. They are going to cross the stage of NAFLD. So always remember, whenever they are going to cross the stage of NAFLD, so they are going to go in a stage of steatohepatitis. That is irreversible stage. So once you get into the NAFLD, cross the NAFLD stage, it is steatohepatitis and it's irreversible. So it's more important to focus on NAFLD at the stage of simple fatty liver itself. Okay. So these are the recent trends in food and physical activity which we are seeing. So good foods have mentioned above, and bad foods are given. So what is the difference is here it's going to contain unsaturated fats. Your good fats is going to contain unsaturated fats. Bad fats are going to contain saturated fats. So all these foods, so mainly the junk foods, they are going to deposit in your wherever the empty space. For example, if there is any empty space or wherever the area there is an underutilization. For example, if you do when we are doing a physical activity involves upper limb and your lower limb, not much in your abdomen part. So there is an empty space in your abdomen part, and so the fat tends to deposit in your empty spaces. So if you're not going to move your upper limb and your lower limb, so what happens? The fat tends to settle down in the empty regions, wherever the empty region or the fat storage regions. So that tends to storage up. So only your physical activity plays an important role. So if there is any lack of physical activity, whatever bad fats we are having, so whatever bad fat diet we are having, that is going to deposit on all the areas, and you are going to have the particular respective diseases. Okay, so this good fat is going to contain a lot of HDL. HDL cholesterol is high density cholesterol, which is a good cholesterol. So this bad fat is going to contain your LDL cholesterol, low density lipoprotein, which is going to present in your fats. So this whenever you take a lipid profile, so we are going to have a LDL, HDL, triglycerides value and the total cholesterol value. So again, this also gets manifested in your master checkup scans or your routine scans. So I always advise this younger generation, where you can see, you would have heard of getting heart attack, your myocardial infarction, all these stroke at the age of 30 and 35 and above. So I would say that you can take up master scans starting from 30. Especially if you are afraid that you are consumed more amount of your fatty diet. So better, I would say you can take about your master scans, check all your parameters, not only your scans, not only your other parameters. You check mainly your lipid profile, blood pressure, heart rate, everything you check up, so that you can have a tracking. So whenever early prevention is the better thing. So whatever early prevention or early intervention is going to be your it's going to have a better yield. So better, I would say, you can take master checkup scans starting from age 30 or 35 and above. Especially if you are going to be a low physical activity and you're going to consume a lot of fat diet, I would recommend to take at the age of 30 itself. And you can take early ones, depends on you, early ones twice or thrice. So it depends on you, but make sure you take up scans and have a regular track on yourselves. And because many of them end at the later stages, and they would regret for it. Okay, so what are the causes? So the main cause I would say is fatty diet and your lack of physical activity in exercise. So whenever we take a fatty diet, so there is a reduction in low high density cholesterols, and there is an increase in your LDLs. Bad fats are getting increased, and as well as your triglycerides levels. So whenever there is a lack of physical activity and your exercise, you're going to increase the risk furthermore. For example, so there are some group of people who take a lot of junk food, but they do a regular physical activity and exercise, make sure they are fit. That means, so the level of increase in the fat storage in the blood, as well as your organs, as well as around your body, adipose tissue, there will be in a low level. But if the patient doesn't same case exist in your lack of physical activity and exercise. So I don't do exercise, but I consume a low fatty diet. Same kind of fat buildup patterns is seen. But whenever we take a fatty diet and you don't do any exercise, but you don't do any physical activity or exercise, you're a sedentary worker or you're a sedentary person who uses more technology to do every other kind of works which we have been doing before. So what happens? So there is underutilization of your fat, underutilization of your body muscles. So automatically the fat occupies in the areas wherever it finds an empty space. So there is a fat buildup in your abdomen, visceral organs, and we can see in your legs as well as your around your body surfaces. So I would say these two are the main reasons which can cause your increase in your risk of your non-alcoholic fatty liver disease. Okay, coming to the risk factors. So what are the risk factors? First is hyperglycemia. So whenever we take a lot of foods or a lot of junk foods, we are going to have a hyperglycemia, which is an increase in blood sugar level. So as increase in blood sugar level, what happens? There is an insulin resistance, which is going to be slowly built up, and body tends to, so there is a lot of work for the insulin to act upon. So you take more amount of glucose to your body, but there is a less or a normal amount of insulin which is provided by your body. What happens? So there is a insulin resistance created. So your insulin tends to not respond to your whatever glucose you are taking up. So this in turn, what will happen? This glucose tends to convert into fat, and that directly deposits in your liver surface. Next is your polycystic ovary syndrome. So among the females, the PCOS syndrome. So this is seen why? Because these patients tend to have a obesity and as well as a lack of physical activity. So as I said previous, so this is your NAFLD is a manifestation of obesity. So whenever we are saying it's a manifestation after your obesity, after your peripheral obesity or a central obesity, direct deposition, the fat happens in your visceral organs only. So next is your hypothyroidism. So hypothyroidism, so thyroid is an organ of metabolic and it's a overall hormone. With this thyroid hormone is going to be secreted in lower amounts. We are going to have a condition known as hypothyroidism, mainly your goiter, we can say. And this hypothyroidism, there is a low metabolic rate. So as a result, your basal metabolic rate tends to low down. So if the basal metabolic rate tends to low down, what happens? Again, there is a increase in your glucose level, increase in your fat levels around your body. There's a loss of appetite. Every other causes happens. On the other hand, if you're going to have a hyperthyroidism, what happens? There is increase in metabolic rate. So these persons tend to be lean compared to a hypothyroidic or a normal people. So next is a central abdominal obesity. So why central abdominal obesity is the fat is accumulated within your abdomen. So within your muscles, next to a layer of the muscles, we are having the fat deposition on your peritoneal regions. Okay. Moving on to your epidemiology. So as of now, so I believe, so I'm clear with the definition and your risk factors and the etiology. So now I'm moving on to your epidemiology part. So what is the prevalence rate? So we are having prevalence rate of 30% among the population, 100% population. Healthy population is going to have a 67%. And liver cirrhosis. So this is the extreme stage where the 30% population gets converted into 3%. So some patients doesn't go into your population of 27, they don't go to the stage of liver cirrhosis. That is the ultimate stage, so where there is a liver failure, there is a stoppage of liver function, there is a abnormal secretion of your liver enzymes. So all the other manifestations starts. So among the Western countries, we can see, as stated by Jacob, Niemann et al. 2012. So we are having a prevalence of 30%. So if the data is going to be 2012, so this year is going to be a 2023, it's going to be more than the 40%. So as you can see here, 2022, the year-wise prevalence, which is done. So 2016 is going to be about 40%, and 2005 is going to be 25%. Why? Because this 2005 year, there was no technological developments or less technological developments. We are using a lot of our body work. So we are having a lot of body work. So we are having a less amount of fat buildup. And your prevalence of other diseases, for example, your peripheral artery disease, your coronary artery disease, so that was coming around the age of 70 or 80 only. But as you can see now, there is increase in the prevalence of your diseases, where it's going to be prevalent at the range of 30, 40 itself. So many of them end up in a myocardial infarction. They go for bypass grafting surgery. So all these happens. Same thing happens in the liver component as well. So next is your worldwide prevalence. So how much the worldwide prevalence is? Healthy population is 68%, and NAFLD diagnosed population is going to be a 32%. Okay. Moving on to gender-wise prevalence. So generally, men tend to have a prevalence rate, higher prevalence rate compared to the women, and this can be explained by the fact such that women tend secretes the female hormones, estrogen and progesterone. So which is the hormone which can have a high metabolic rate compared to the men's hormone, testosterone and the other hormones. So this hormone has a metabolic rate such that it reduces the fat buildup. So not only in the organs, it also reduces the fat buildup in the coronary arteries. So this is the reason why the females tend to have a less heart attack compared to your male population. Next is the prevalence rate of NAFLD with comorbidities. So these comorbidities, as you generally know, we have a hyperlipidemia, which is increasing your lipid profile values, mainly in your LDL cholesterol, decrease in your HDL cholesterols and triglycerides. And we are having obese adults and the diabetes. So all these are interlinked. So all these components are going to be interlinked. So doesn't mean these are separate components. So hyperlipidic patient can have a diabetes, obese patient can have a diabetes, and there is no necessity that they should have a hyperlipidemia. They can have a elevated lipid levels, but they don't cross the alarming levels of lipid levels. So it's hyperlipidemia is 45%, obese adults is 40%, and diabetes is 15%. So it's given by Stefano Bellantino of 2010. Okay. Next is moving on to prevalence in Indian population. So why I took Indian populations, you might be saying, so we are speaking about, we are in Indian country, and we are speaking about, we should speak about Indian population as well. So I took the fact which is done by Shalimar et al. 2021, prevalence of non-alcoholic fatty liver disease in India, which is a systematic review. So they have collected more articles from worldwide as well as from the India, and they have collected the prevalence rate. So as you can see, the non-obese is a 8%. So there is increasing trend. That means non-obese people also is having a tendency to go and develop a non-alcoholic fatty liver disease. And next is the population of obese percentage, which is going to have a 42%, as common as understandable that we are having alarming lipid levels elevation, there is insulin resistance. So automatically these population tends to develop 42%. And children. So these as explained, we are having technological developments, junk food, lack of physical activity. The children doesn't tend to play, they're glued to their mobile phones, mobile phone games are increasing. So there is a lack of physical activity and exercise. So that lack of awareness also, I would say, among the exercise. Studies. So there is a lack of physical activity and exercise among the children as well. So next, we are having the adults population of 26% as well. Okay. So what is this? Moving to the pathophysiological process of NAFLD in steps. So these population or NAFLD is a disease, no alcohol. So you don't consume alcohol, but still you end up in your fatty liver disease. So we are calling it as non-alcoholic fatty liver disease. So these are the steps. So I will start with this step of fat accumulation. So you take lot amount of fatty diet, and this fatty diet tends to go into your de novo lipogenesis. Genesis is development of lipids. So the development of this fat accumulation is development of lipids, and this lipids, when generated in larger amounts, what happens tends to develop into fatty lipids. Apart from the lipids which are getting deposited as adipose tissue in your various organs and your other skin parts. Apart from this, we are having the increase in levels of.
Sir, you are struggling.
Sir, can you hear me?
It's all right here, sir.
Hello.
Please continue, sir.
Okay. So there is an increase in the hepatic lipids. So as a result, what you can see is there is increase in lipid peroxidation. So what is this lipid peroxidation is? So there is an oxidative stress. Oxidative stress, once the fat gets into the hepatocytes, we are having the lipid peroxidation. So this lipid peroxidation is an oxidative stress. So there is a fighting of hepatocytes. So on the fatty accumulation, and so then we tend to have a free radical. So this is a free radical and a radical of stellar, and we are having the inflammation process. So once the organ tends to fight the fat buildup, we are having the creation of inflammation process. So okay. So what is this Kupffer cell activation is? These are the response of cells which is going to have a cell injury liver. And these are the stellate cells. So what is the stellate cells we are going to have is this, the stellate cells which are going to replace your lost cells. Whenever there is a dead hepatocyte, these are cells which is going to replace. So whenever the tends, so as I said earlier, that liver tends to grow, but so there is a larger amount of hepatocytes destruction and hepatocytes fatty liver buildup. So there is lack of Kupffer cells and there is a larger amount of buildup of stellate cells. So there is a stellate cell presence. So what happens? Automatically there is a scarring and fibrosis of your liver tissue presence. So this is a mitogen activated protein kinase pathway. So it's a biochemistry related. So which is going to create as soon as your inflammation process is created, we are going to have a insulin resistance again, which is going to be a viscous pathway. Okay. So moving on to the overall summary of the pathophysiology. So if a patient is having obesity, so automatically triglycerides are converted into free fatty acids from the adipose tissue. So free fatty acids are getting liberated and they're converted into triglycerides, and some amount of fats are getting deposited on your liver part as well. So we are calling it as isolated steatosis. That is, all the other areas will be functioning in a normal manner. There won't be any fatty buildup. Some areas of the liver will be having an isolated fatty buildup. Okay, so there is as you can see within the cell, there is a fatty buildup as well. So here you can see the nucleus is free of fat, but this nucleus is getting fatty buildup. So whenever there is a new portion happening within your within the cell, that cell tends to fight back. And we are having a stage of reversible. So whenever this stage is diagnosed, automatically we can still go back by only physical activity in exercise. If we increase your physical activity, reduce your exercise, automatically you are reversible. But when you progress to a NASH, that is the inflammatory stage, I would say again still reversible, but only with medications. So you have to do a lot of physical activity, exercise, reduce your fatty diet, and you have to go to your reverse. You have to go towards your along with medication, then we can go to the stage of NAFLD back. But when it goes to beyond NASH, that is, so when the NASH happens, there is inflammation process created. So whenever we take a biopsy, we can see the inflammation process is created. And whenever this cirrhosis stage progresses, we are having irreversible stage. Why? Because so already this stage, the liver cells tends to fight back. Again, here also it tends to fight back. we're having an inflammatory stage happening. But when we cross to the stage of cirrhosis, so there is dead hepatocyte. So dead hepatocyte is, so it's already fought back, that tries to move the fat away from the cells so that it can, the hepatocyte can function in a normal manner. But the stage crosses and automatically the hepatocyte dies. So when the hepatocyte dies, we are having a stage of scarring and the fibrosis. So cirrhosis and fibrosis and cirrhosis are the later stages of your NAFLD. So this webinar tends to create an awareness among the population who is going to have obesity, so that whenever they can go for an NAFLD stage, that time itself they have to tend to reverse back. So otherwise, if they go to NASH or cirrhosis or fibrosis, it's almost reversible or irreversible or completely irreversible. Okay. So next, moving on to your NAFLD versus obesity. I hope I'm clear with your pathophysiological steps. And so what is the difference between your NAFLD and your obesity? So NAFLD is a manifestation of obesity. So once the obesity stage crosses, we are going to have the manifestation. That is, after there is a utilization of all the extra spaces, all the fat deposits in your region around your adipose tissue under your skin, that deposits in your NAFLD, in your fatty livers. And it's going to be associated with visceral fat deposition more compared to your subcutaneous fat deposition. So we are having two types, mainly a lean NAFLD, and we are going to have a obese NAFLD. Okay, so what is this obesity is? It is an increased deposition of fatty substances under adipose tissue. So there is less amount of fat deposition on your liver, or there is zero amount of fat deposition on your liver. But still you are having obesity, and you'll be having the increasing elevation of lipid levels and these levels. So once you cross this level, or once you are still staying in that with the fatty diet and you're continuing with the fatty diet, what happens? Then only you are going to progress to your non-alcoholic fatty liver disease. So this lean NAFLD, why it happens is whenever you're having a poor metabolism. So apart from fatty diet, if you're having a poor metabolism, and then only your lean NAFLD happens. So this is a very rare form compared to your obese NAFLD. So whenever we tend to take a cross-sectional survey among the obese people, whenever we take a scan, we are going to find out a NAFLD is going to state as grade 1 fatty liver. So which you are going to see on the upcoming slides as well. So obesity, as you know, we are having two types, central and peripheral obesities. Okay, moving on to your NAFLD versus AFLD. So AFLD is alcoholic fatty liver disease. So what happens here is, so alcohol is a toxin. As you know, alcohol is a toxin. Whenever we take alcohol, it's absorbed into your bloodstream, and liver is the only organ which is going to metabolize that. So it's going to neutralize, the alcoholic effects. So whenever the alcohol tries to go beyond the limit, you're taking more than the limit of daily intake or daily recommended intake. So what happens? This liver is unable to reduce the level of toxin in your blood. Then automatically you're going to progress to a stage of liver cirrhosis, and directly to the stage of liver cirrhosis, and we are going to lead to decompensated liver failure. So this is NAFLD is associated with 0 to less amount of alcohol intake. That is, whoever is taking the amount which is recommended amount, but still taking a more and more of fatty diet, they tend to go towards a non-alcoholic fatty liver disease. Then just common among all types of people. So there is no people that, so they, whoever is taking a fatty diet, always they tend to go towards a non-alcoholic fatty liver disease. And it's only associated with faulty diet and lack of physical activity. You don't do physical activity, you take a lot of fatty diet, automatic or faulty diet, you tend to skip your breakfast, you tend to skip your meals, and you're going to take a lot of fatty diets and a lot of junk foods, noodles, all these things. They're going to end up in non-alcoholic fatty liver disease. Yes. So these fatty degeneration of your cells occur to a more degree. Why? Because there is more and more amount of fatty buildup. And when checking with your alcoholic fatty liver disease, it's associated with chronic alcohol intake and common disease among your alcohol drinkers. exaggerated by fatty disease. So that if there is there are population who tend to take more amount of alcohol, they tend to take more amount of fatty diet also. So they directly progress into alcoholic fatty liver disease, and they progress more faster compared to the other group of people. So always this alcohol is going to be a toxin. So better I would say avoid alcohol, so that you are going to avoid your alcoholic fatty liver disease. So this why here fatty liver degeneration of disease occurs to a less degree is there is less amount of fatty deposition, but your liver is tired of neutralizing the toxin which is present in your alcohol. Okay. So automatically the liver is reducing the function, is deteriorating its function, directly are progressing into liver cirrhosis. Okay, moving on to the stages of NAFLD and its progress. So we're having a stage 1 of simple fatty liver, stage 2 of non-alcoholic steatohepatitis. We are having a stage 3 of fibrosis of liver, stage 4 of cirrhosis of liver. So this is the extreme stage, and the most extreme stage is going to be a decompensated cirrhosis of liver. So what is the difference? We are going to see in the upcoming slides as well. Okay, so mortality, the death can happen in cirrhosis and decompensated stages of liver along with the existing comorbidities. So if you are going to have a cirrhosis of liver along with all other comorbidities such as hyperlipidemia, if you're going to have diabetes mellitus, hypertension, automatically the rate of death, the mortality is more in these kind of populations. Okay, moving on to the stage 1. So this is a simple steatosis or the simple fatty liver. There is just fatty deposition on the surface of the liver, on the fatty liver cells, on the hepatocytes, on the just a mere covering like a fat on the surface of the liver, and there is no ballooning or the inflammation stages in the hepatocytes. So this fatty deposition can be graded as less than or greater than 5% of the no hepatocellular ballooning. So whenever what is hepatocellular ballooning is, so hepatocytes accumulating the fats and it tries to balloon. So it tries to enlarge in size, and then only your inflammation of your hepatocytes starts. So if you're going to have a less than a 5% of the fat deposition, automatically you are having a healthy liver. If there is more amount of fatty deposition, about greater than 5%, we are going to have a more amount of we are going to have graded as grade 1 fatty liver. So this stage goes through a grade of 3. Grade 1, grade 2, grade 3 fatty livers. Then only progresses to the stage of non-alcoholic steatohepatitis. Okay. So this is an increased fat buildup with hepatocellular ballooning. So already the fat is well within inside the hepatocyte, and there is an inflammation process which has started about, and there is no evidence of fibrosis. So that means the hepatocytes are still fighting about and tries to remove the fat, which is trying to neutralize the fat and move the fat away from the body, away from the hepatocyte, so that it can function to a greater extent that amount. It's more than 25%. When we are moving to the stage of fibrosis, so we are having fibrosis of liver. Liver tends to develop a scar tissue. So the cells, liver is not growing, liver is staying in the same size, but liver cells are dying out. So we are calling it as a fibrosis of liver. So this is little bit different compared. So you'll be saying liver tends to grow. So but this liver cells are tends to die. As a result, we are going to have a scarring tissue. So as like after a normal injury to our skin, there is a scar, right? So which is going to be a non-pliable one. So it takes a little bit time also, but this is irreversible stage. So next, moving on to the stage where we are having a cirrhosis. That is, this stage fibrosis, we are going to have a reduction in functions, but that there is not going to be any stoppage in functions. But this stage, or where we are going to have a reduction about 90% or 80% of functions, and this we are calling it as cirrhosis of liver or liver cirrhosis, where we are going to have an extensive degeneration of liver parenchymal cells with abnormal nodules. That is, so that there is a scarring to extent, there is a creation of abnormal nodules in the liver itself. So this is a chronic progressive disease. So once it's done, automatically progress till stage in the liver stops. completely functioning. So next stage is the decompensated stage of liver cirrhosis, and it's going to go to a stage of acute deterioration of liver function in patients. So that means they're going to have a extrahepatic complications, and I'm going to list out these complications in the upcoming slides. So we're having jaundice, ascites, and hepatic encephalopathy. So hepatic encephalopathy is the same toxins, whatever the toxins which is going to be released in form of elevated liver enzymes, that is going to affect your brain functions. And we are going to have the jaundice, which is going to be again, liver enzymes is getting elevated, yellowish discoloration of the skin. Acids is going to be a fluid buildup in your abdomens. Fluid buildup, so automatically there is a ballooning up of your abdomen. So it will manifest as your central obesity as well. Acids is a fluid buildup of in your abdomen. Okay, moving on to your stage simplified thing I'm going to explain. So we're having a healthy liver, fatty liver, fibrosis, and cirrhosis. So as you can see, this is reddish brown in color, slowly turns in a yellowish color, and this yellowish color is a fatty deposit, so it's still reversible. And when it goes to a stage of fibrosis, again it loses its color. Why? Because the yellowish color turns into the brown color, where we are going to have a reduction in blood supply. Why? Because already there is a death in your hepatocytes liver, and there is a cirrhosis. Again, liver tries to modify itself so that it tends to fight back. But this cirrhosis, we are going to have a nodulous structure surrounded by an area of some fibrosis as well. So this stage, almost the liver is stopping its functions. Okay, how this NAFLD is going to progress? So NAFLD is present, as I said earlier, we are having 20 to 30% of general population. So automatically, as I fear, so this general population is going to cross more than 40-50%. When we take a recent survey, it's going to cross than 40-50%. And whenever we take a survey, it's going to show up more than NAFLD, more of fatty liver patients. So we're having progression to type 2 diabetes as a result of insulin deficits, and we're going to progress to cardiovascular disease as well. And we are going to have progress into a NASH. We are going to progress into among 5 to 10% in NASH people, and fibrosis occurs in 38% of the other people. Cirrhosis occurs in 30% of the people. So this cirrhosis people tends to go to a decompensation stage, where if they're not going to do a liver transplant, they're not going to do any proper intervention, they tend to do a decompensation stage. That is 5 to 10%, where they're going to have a multiple complications like hepatic encephalopathy. All the other complications will happen along with the liver. All the other organs are going to be damaged. Your kidney is going to be getting damaged. Your liver is going to get damaged. Automatically, we're having the decompensated stage. That is, liver is not trying to compensate because liver is already lost the function. Then we are having the carcinomous cells. So next is your simple steatosis. So some people will, majority of the people goes for simple steatosis, that is only fat deposition. There is no other inflammatory deposits. So there is a stable disease. So if they are going to intervene here itself, automatically they are going to tend to develop a stable disease. Very less than 1% of the population, they are going to develop a carcinomatous in the stages. It's going to be very, very rare populations. Okay. Moving on to the signs and symptoms. So I have hope till now this is clear. So when we move on to the signs and symptoms, simple fatty liver, there is no signs and symptoms. When it goes to a stage of more fat deposits, they go towards a stage of we are feeling loss of, they'll be having a feeling of loss of appetite, nausea. We are having a abdominal pain, weight loss, pale stools. So pale stools always indicates there is a fatty diet. Fatty diet, you would have taken a fatty diet. So we're having a pale stools, and you're having a easy bruising, easy fatigue. So fatigue is, so automatically if you're losing a loss of metabolism, so your body tends to work less. So we are having a loss of, we're having excessive fatigue. So whenever you try to do a simple work, that also causes excessive fatigue. Why? Because you're having a lack of physical activity. You're already having a sedentary activity. So automatically you're going to go to a stage of excessive fatigue. And at last, so this is a jaundice, which is less common. So simple fatty liver disease. So as a normal population, you don't have any symptoms or signs you present with. obesity, or you may not present with obesity as a lean NAFLD, lean non-alcoholic fatty liver disease also. Okay. So what are the signs and symptoms at your cirrhosis stage? So when we go to later stages, so as I said earlier, we're having encephalopathy, we're having a spider angioma. Spider angioma is nothing but enlargement in your veins and arteries, automatically you're having a spider thing. So like your varicose veins, which is going to happen all over the body, we're going to have a spider veins. And we're having lack of body hair, muscle wasting, widened blood vessels. So we're having ascites, fluid buildup, that is your peritoneal fluid is getting filled up. So to your response, we are having a red palms. Red palms is automatically your blood circulation is getting reduced. There is more amount of fatty diet, so the blood is getting stagnated. And we are having jaundice, which is going to be a yellowish skin and eyes. So mostly the patients tends to go towards the doctor when they go to a stage of jaundice. So tend to rush towards the doctor. My skin is yellow, my eyes are getting yellow. So already they are gone to a stage of cirrhosis. Okay. Now moving on to the investigations. So I would like to alert the junk food lovers. It's high time you have to take a liver checkup, and mainly your blood lipid profile checkup as well as a liver checkup. Okay. Moving on to the diagnosis. So what are the diagnoses we are having? Mainly we are having a CT scan, MRI scan, and well as a ultrasound scan. So ultrasound scan, which is going to be a gold standard diagnosis of your fatty liver disease. So this was the scan I was saying about, where you can see which is going to be done at the stages of master checkup. So when we take a master checkup, automatically we are going to go for a urine examination, we are going to do for a stool examination, complete blood profile, and we're going to go for blood lipid profile, we are going to go for some hormones, we are going to go for ultrasound scan of your abdomen. So this stage only the patient tends to notice there is a something abnormal which is going in my liver organ. Okay, it's a non-invasive tool. So it's going to send the ultrasound waves. So it's a high ultrasound waves, and your liver is going to echo back. And your liver is going to echo back the liver, and we're going to have the imaging. So your ultrasound will reveal a diffused echogenic texture pattern in the NAFLD. So when we are going to have a normal liver, so that we are going to have a normal echogenic pattern. So here we are providing the sound signals, and the liver is echoing. We are going to have a echogenic waves that is normal in a normal level. But when we are having a non-alcoholic fatty liver disease, we are going to have a diffused echogenic pattern. And we are going to have an advanced stage of your non-alcoholic fatty liver disease. That means you are already in a grade 3 fatty liver, and you're about to go to a stage of inflammatory stage. That means we are going to have a reduced echogenic pattern. So that is fat tends to not reflect back. So we're having a normal ecotexture pattern seen in normal patient without any kind of NAFLDs. Okay, this scan, how it is done? So it is done in a supine lying position, which is done in your side lying position as well as your posterior part of your right upper abdomen. So just below your ribs, they are going to do a ultrasound scan, which is going to take less than 5 minutes, in a side lying position. So whenever we take in a side lying position, we are going to cover the anterior part, we are going to cover the side part, we are going to cover the posterior part. So which is going to encompass, we are going to cover the whole part of your liver as well. Okay. So next is your blood investigations. So whenever we try to correlate the lipid profile along with your ultrasound scan, it tries to 100% match. Why? Because we are going to have a reduction in HDLs. So we are having a 30%, 35 milligram of deciliter, which is normal and which is going to be usually above. Okay, but whenever we have a high lipid profile, we are going to have a less than 35 mmHg in your deciliter. Whenever we are going to have a low density of cholesterol, we are going to have cross more than 160 to 190 of milligram per deciliter. And when we are going to have a triglycerides of more than 200 to 400, 500, we are going to call it as an alarming level. So generally, your triglycerides should be less than 200, and your LDL should be less than 140 milligram per deciliter. And your total cholesterol is going to cross more than 240. That is going to be a high risk as well. So the amount of obesity can be measured by LDL, HDL, triglycerides value, as well as the LDL, HDL ratio. So this, whenever we are having obesity, I would recommend first you check with your lipid profile. If you're going to have a lipid profile more than of like these values, then you try to take a ultrasound scan to ensure that. So you're in the stage of only blood level fat elevation, not in any kind of organ wise deposition is avoided. So whenever we take a blood lipid profile, that stage itself will rule out whether we can take a ultrasound scan for a safer extent or not. So if you are going to have a high risk, once I'm repeating, we're going to have a high risk, these kind of values, automatically I would recommend that you have to, or to alarming levels, you're not crossing the level, but you're still more on the more levels. What I would say is you can directly go for a ultrasound scan. So to ensure that we are not in the particular stage. Okay, these elevated levels indicates the severity of obesity, which will directly impact your liver. So if you're going to have a lipid profile elevation, automatically the fat is, so already the fat is more circulating in your blood serum. So automatically we are having this fat is going to deposit in your organs, arteries, everything, and we are going to have a deposit in your liver organ as well. Okay. Moving on to the other organs, we are having other test investigations. We are having liver function test, which is done in the later stages to find out how much the liver is functioning. So we have diagnosed. First stage, you take a lipid profile. Okay, you have a higher level of lipid profile. Then you take ultrasound scan that shows that grade 3 fatty liver or a NASH steatohepatitis, you're already in the stage. So now it's the time to take a liver function test. No need to directly go to the liver function test. We are having bilirubin. So these are the hormones. So these are the hormones which is exiting from the liver, which is secreted by the liver in normal amounts. But when we are having a stage of more than the fatty deposition, these hormones or these blood parameters tends to elevate. So we're having a blood bilirubin, which is going to be 0.3 to 1.2 milligram per deciliter. Aspartate aminotransferate, we call it as AST, ALT, which is going to be less than 35, less than 45. So all these are blood biomarkers should be less than the levels, but when it crosses the limit, so usually we call up biomarker. Why? Because so they're trying to reflect the organ. How much is the organ tries to function? How much is the organ functioning? It tries to reflect back. Okay, so this whenever we are going to have a more amount of increase in liver function test, these values that shows that your liver is in a stage of a dangerous level or an alarming level. So the action has to be taken immediately. Okay, so this first stage of NAFLD, there is no elevation of your biomarkers. So there is no symptoms, there is no elevation. So we are having a reduction in your lipid, only we are having an elevation in your lipid profile values. Or there can be a stage of grade 1 fatty liver if you are going to take a ultrasound scan of your abdomen part. When the period of inflammation starts, there is an increased level of your biomarkers. Then when liver is in irreversible stage, so irreversible stage, that automatically your biomarkers moves on to your alarming levels, and at one point of time liver stops functioning. Okay. Next is your liver biopsy. So this is another gold standard diagnosis of your fatty liver and not much fatty liver. We are going to the stage where we are going to go for non-alcoholic steatohepatitis. So this stage or this liver biopsy is recommended when there is a already inflammation process which has started in your hepatocyte, and we want to confirm that whether there is inflammation process is started in the hepatocyte. Then we go for a liver biopsy. So liver biopsy tends to through injection fine needle, we are going to collect the liver cells. We are going to examine under the microscope to find out whether there is any increase in your cells, mainly your phagocytes, mainly in your inflammatory cells. So if there is any inflammatory cells, increase in alarming levels of increase in your inflammatory cells, automatically that shows that you've already progressed to a stage of non-alcoholic steatohepatitis. So it's recommended as a part of differential diagnosis to rule out whether other disease also. So suppose if you're having a jaundice kind of symptoms, and still if we want to rule out, so if you want to rule out whether you're having any impact in your liver cells, then we can go for this liver biopsy, where it will rule out whether there is any inflammation process which is going on in your liver. Okay. So what are the other investigations? So first investigation I would say is, your ultrasound scan. Then next is your lipid profile value. At last, whenever is going for a liver function test, it's going for a liver cirrhosis stage only. Okay. And at last we are having a liver biopsies. So this other investigations such as CT scan, which is a combination of X-rays and computer technologies, and we're having a MRI scan, radio magnet based. Compared to MRI scan, compared to your CT scan, MRI scan is much safer. We can take repeated times. Why? Because it's a radioactive waves. This is only a magnetic kind of waves, which is not going to be providing harmful whenever we take any repeated number of investigations. Then this elastography. So this is a newer method of taking the amounting or estimating the amount of liver fibrosis. How much is your liver fibrosis happen? How much is your liver fibrosis to extent? Like we can grade as you're having 80% of liver fibrosis. You're having a stage of 70% of liver fibrosis. That is almost it's going to find out how much liver cells are lost. How much liver cells are lost? How much liver cells are going to function exactly? Okay. Moving on to the prognosis of NAFLD. So I would say this NAFLD is completely 100% curable, preventable, everything. Then it's in the stage of simple fatty liver alone. Otherwise, just if you reduce your fatty diet, automatically you don't do physical activity also, you're going to reduce your fatty buildup in your fibrosis of liver. But if you're going to go to a stage of increased fatty liver deposits, then automatically you're going to go for exercise. You're going to do physical activity. You're going to more physically active, do exercise, lot of exercise, and need some medications which are going to reduce your, which are going to prevent inflammation process happening in your already grade 3 fatty livers. So it's NAFLD is reversible with effort of increasing physical activity, exercise, and later stages with medications. Okay, prognosis difficult when it goes to NASH and inflammation is already started. It's almost irreversible to irreversible. Okay, so what are the complications? So when we are having an NAFLD, automatically you're going to have complications. That is hepatic complications, as you know, expected. Jaundice is an expected one, but some extra hepatic complications also present, as stated by this author, Tomino, 2020. So we're having chronic kidney disease, gastroesophageal reflux, obstructive sleep apnea, or commonly known as OSA, hypothyroidism. So this chronic kidney disease. So whenever there is a loss, buildup of toxins in your blood and your liver is not functioning, automatically you're going to have a kidney disease. So that is going to impact the other organ from function. So your kidney is also a filtration organ, but your liver is a neutralizing and a filtration organ. Then we are having a gastroesophageal reflux. So why this gastroesophageal reflux tends to happen is whenever we are having a ascites, the fluid buildup in your abdomen, automatically there is increased pressure in your abdomen, and whatever we tend to eat, automatically the reflex of your acid, reflex of your food happens in your esophageal regions. Then we are having obstructive sleep apnea. Obstructive sleep apnea happens. Why? So again, we'll relate to the acids. Whenever there is a fluid buildup, automatically we are going to have a reduction in the function of diaphragm. So there is an inhibition of the diaphragm from functioning properly. So what is the function of diaphragm? So the diaphragm function is to enlarge your abdomen. That is, diaphragm descends, and whenever we take breath, diaphragm descends, and there is enlargement in your abdomen. And when we expire or exhale, automatically the diaphragm goes back to your upper portion, and your abdomen goes back to your normal portion. But when you're going to have a ascites buildup, so the patient is unable to sleep properly, and we are going to have a less functioning of a diaphragm. Patient is unable to sleep properly. The snoring pattern happens. Then we are having a hypothyroid, when we are having a hypothyroidism. So as I explained, so this is a risk factor and this is going to be a complication as well. So it's interlinked. So we are having hypothyroidism. People can also develop NAFLD. NAFLD people also can develop hypothyroidism. So whenever the body's basal metabolic rate reduces, the metabolic rate reduces due to a fatty diet or these kind of problems arises, mainly your hypothyroidism. Okay, what is the medical intervention in NAFLD? So whenever we go to a doctor, so he for this fatty liver disease, he tries to give a pharmacological therapy, mainly in the form of all these pharmacological drugs. So there might be a brand name different, but the basic chemical composition is going to be the same. So we are going to have an insulin sensitizers. So what is this insulin sensitizers? So that is going to reduce your insulin resistance. So that is going to increase your insulin levels. So that automatically you're going to have a reduced amount of fat deposits. So we're having metformin, thiolidinolins, incretin-based therapies, and we're having lipid lowering agents. So lipid lowering agents are given to reduce your lipid levels, mainly statins, fibrates, PUFA, polyunsaturated fatty acids, and cytoprotective. Cytoprotective is nothing but protecting your cells and antioxidants. So if you're going to take a lot of antioxidants in your food, automatically the amount of liver, amount of the fat, the amount of the cell destruction is going to be reduced. So all these vitamin E, betaine, so all these are antioxidant agents. Then we are having anti-TNF, tumor necrosis factor agents, mainly in the form of pentoxifylline and monoclonal antibodies. So whatever pharmacological drugs we are taking, along with this, you have to do 100%. You have to do exercise. Then only it's going to go for effectiveness. Why? Because so whenever we are having a insulin increase, and automatically there is a reduction in glycemic. So when we do an exercise, or it is going to supplement, it's going to be a main factor in your pharmacological therapies, making effective pharmacological therapies. Okay. Last part we are having is the physiotherapy evaluation and the exercise protocol. So this physiotherapy evaluation, whatever the equipments, whatever the pictures you can see here. So this is one is your waist hip circumference. We are having a BMI, waist hip circumference. We are having skin fold thickness. We are having bioimpedance. So BMI, as known earlier, so this BMI tends to find out whether you're obese, whether you're class 1 obese, class 2 obese, class 3 obese, it tends to find out. But compared to this, all the other things are going to quantify. Why? Because why I'm saying BMI is not going to be a valid tool compared to all the other tools. Why? Because for example, if we take a participant, weightlifting champion, so he's going to say weight of the same weight. Okay, so for example, he's going to weigh 100 kg or 120 kg, but he's going to have more and more of muscle part. Okay, but compared to the fat part. But when we tend to take a normal individual who doesn't do exercise, he's going to weigh the same weight of 120 kg. But when we take a waist hip circumference, when we take a skin fold thickness, when we take a bioimpedance value, we are going to have a more amount of fat. Okay, so when we tend to take skin fold thickness bioimpedance for the people who is having a same weight but a healthy population in the form of exercise training people, these values are reducing. But when we take a value for the people who don't do exercise but same BMI, class 1 obese or class 2 obese or class 3 obese, even morbid obese also, these values tends to go worse. Okay, so waist hip circumference, as you know, waist hip circumference can be done at the level of umbilicus level and at the level of greater trochanter level, mainly in your big buttocks region, which is going to provide a ratio. So this value should be less than 0.85. Then we are having, it is going to more than cross 0.85, we are having a value of calling it as obesity. Then we are going to call have skin fold thickness. So skin fold thickness, which can measured by skin fold caliper. So this tends to measure the skillful thickness. How much is the fat deposit around your adipose tissue? So this is not only done in your abdomen region, it's done in your subscapular region, it's done in your pectoral region, it's done in your umbilicus region, it's done in your tricep region. So these are the common areas where the fat is getting deposited. Coming to the lower legs, we are having fat deposition in your lateral part of your thigh regions we are going to have. So whenever we tend to take a tenfold thickness, the skin is little bit harder and the skinfold thickness is going to show a increased value. Then bioimpedance. So bioimpedance is it's going to send a microcurrent to the throughout the body, which is going to analyze the fat content. So when we tend to send a microcurrent, so my current is an insulator, correct? The fat is going to be insulated. So whenever there is more amount of fat present in your body, this current, the amount of current we input and the output is going to be, so if its input is more, the output is going to be very less only. Okay. But if you're having a normal person, or whatever input is we are giving, the output is also going to be the same. But when we go for a fatty people, the output is going to be less. So it is an indirect measure of your fat content present. Also, it's going to measure how much is your muscle mass, how much is your fat mass, everything. So always remember this bioimpedance analyzer. It's a little bit costlier, but it's affordable as well. And this fat bioimpedance device tends to find out your fat, how much is fatty composition, and always fat values are more in women population compared to the male population. Why? Because the women population have more amount of fat deposition in the breast region and other regions, in the hip regions, compared to the male population. So always bioimpedance values will be higher in the women population. Okay, moving on to the exercise testing, and then we'll be going on to the exercise training protocols. Okay. So why we have to do a exercise testing? So first we have to find out whenever the patient is approaching to a clinic. So mostly the patient doesn't approach to a clinic with showing a report. So I'm having a fatty liver. I'm having because he's also not having. He will tend to come to a clinic of reducing your weight only. So when we take all these investigations, we are coming to conclusion that so these patients are obese patient and the patients need to reduce their weight. So why we do exercise testing? So first we have to find out whether there is a diagnosis of latent heart disease or an underlying heart disease. That means if the fat is getting deposited on your liver, automatically there is some amount of fat deposits and there is a loss of cardiac fitness which is going to be present in your heart as well. So when we do a exercise training, so automatically when we tend to teach some exercises for these patients, what will happen? These patients tend to do an exercise. They will say, I'm unable to run, I'm unable to do the exercise. Automatically, that reduces the confidence levels in the patients. So first we have to find out what is the existing level of exercise capacity through your exercise testing protocols. Then we have to go for the appropriate exercise training procedures. And so this will help you in quantifying as well. So based on the pre-exercise testing and post-exercise testing protocols, so we are able to come to a conclusion how far the individual has improved in terms of exercise capacity. And later on, when we take your lipid profile ultrasound scan, then also we can try to find out whether there is any reduction in the levels also. Then, when we are having evaluating response to conditioning or preventive programs, then to evaluate cardiovascular functional capacity, particularly as a means of screening prior to the strenuous work exercise. So whenever the individual is coming in terms of, I want to reduce my weight, I want to do a fitness kind of exercises, I would recommend first you do the exercise testing, find out what level the patient or the individual is in, then you go according to the protocol. Sometimes the individual might look healthier, but his exercise capacity will be very less. Okay, so we tend to give a more amount of exercise protocol, larger amount of exercise protocol in terms of higher intensity. These patients tends to go for a relapse. So better, I would say, first test their levels, then you go for the exercise training protocols. Do a customized exercise protocol for the patients. Next is increase individual motivation for entering and adhering to exercise testing programs. So we can put a challenge as well, like so this is your current existing level, your exercise capacity this much. Then when we go to you do exercise for these 1 month or 2 months or 3 months of exercise, then we will check how much is how much is this, and patient also will be interested. So once we generate a patient interest among these patients who want to reduce the weight, automatically they will be in the stage of okay, I'm ready. So let's make a target of reducing my lipid levels, reducing my fat deposits, reducing my liver function test values. All these will be a major factor. So mainly we have to be very careful when we are testing for a liver cirrhosis patient. Why? Because already that is a very deconditioned patient. So we have to take a low excess testing protocol compared to the moderate or a higher excess testing protocol. But if the patient is coming with the is an young individual and is just a obese candidate, he wants to do a fitness or a weight reduction programs, then what we have to do is we have to go towards a moderate to a higher excess testing protocols, such that we can find out the accurate test. So objective is nothing but we have to find out the how much is the patient's exercise capacity. Okay. So protocols, what are the protocols we can use? Is whatever the protocols we are using for the obesity and sedentary individuals can be used as a exercise testing. So mainly I would recommend this field test. If you're going to do a field test, so you don't have any equipment such as treadmill or a ergometer, I would recommend you can directly go for a 6-minute walk test or a 12-minute walk test, or else you can directly go for a 1.5-mile Rockport walk test. Next, if you're going to have a treadmills based setup, I would recommend you can go for a modified Bruce protocol. So what is the differences? So Bruce protocol is usually used for individuals who is having a moderate to higher capacity. This modified Bruce protocol is going to be used for a patient's modified Bruce protocol is going to be used for a patient where they are having a reduced levels of exercise. So the intensity or the level of elevation. So what is the differences between Bruce protocol and modified Bruce protocol is the level of elevation is less. In the level of elevation doesn't start. For example, in Bruce protocol, your elevation, treadmill level of elevation starts in the first stage itself, but it will take 3 stages or 2 stages for the modified Bruce protocol. The patient is allowed to walk for 2 stages at a particular speed, and then only your elevation starts. So what happens? The sedentary individuals or obesity individuals are ready to cope up. So this is the advantage of using your modified Bruce protocol compared to your other Bruce protocols. Okay, when we have a ergometer protocol, so when we go for it, we can use a common thing, A-strand ramming cycle ergometer protocol. Okay, so what is the exercise protocol, which is going to be a major issue? I have done in my dissertation. So this beyond this topic of interest, this is my dissertation part as well. So this was my sole reason. So why I took this topic to be presented in this platform and exercise protocol. So explaining my part of dissertation, which is going to be published in another few weeks. So literature review, I have done a literature review. So literature review was done with mesh terms. These are the mesh terms I used. NAFLD, exercise, effectiveness, aerobic, and resistance. So I tend to find out how much, I try to find out how much exercise protocols are available. So as awareness is less, for example, when we tend to take a search in your PubMed or Google Scholar search engines, your common diseases such as COPD, all the COPD, chronic bronchitis, all these asthma, all these diseases are coming in huge numbers. That is thousands and thousands of numbers we are having. But when we take a less common disease, less known disease or less awareness disease such as your fatty liver or a kidney disease, we are finding very less articles. Why? Because awareness is less, and awareness less, and articles also going for less. So we're having 168 articles which I found out in 2013 to 2020, and which is 26 relevant RCTs. So I did a survey type of a study, so I took 26 RCTs. Then I took 24, I could find 24 international articles, only 2 Indian articles. So that this itself shows that we're having less awareness among the Indian population. Then we are having looking for the available exercise protocol. So I tried to find out what exercise protocol they were using, and I tried I found out aerobic exercises were 12, resistance exercises were 6, and I found out both aerobic and resistance exercise. So some authors, some physiotherapists gave both aerobic exercise for the patients. Okay. So these are the recommendations. So when during my survey type, so I conduct a survey among the physiotherapists. So these are the recommendations which are given by Indian physiotherapists. So if they are able, if they're going to do any exercise protocol for these awareness, first of all, awareness was very less among among our Indian physiotherapists. And what could I found is they were saying about 3 days per week you exercise at rate of 40 to 60% of target heart rate, so which is good advisable for a sedentary individual. So available evidence shows as 60 to 80%, but I would say you start with 40 to 60% gradually. Like first you do a supervised exercise training, always, whatever condition it is, whatever cardiorespiratory condition or whatever the condition we are having in the NAFLD condition, whatever stage it is, you do a supervised exercise training. So if the individual is confident, or if you don't find any kind of problems happening or complications happening within the individual, then we can go for a unsupervised exercise training. So as the patient do regularly in his home setup, report weekly once or monthly once, then you assess the exercise capacity, the particular individual, find out whether he's improved or not. Then you go for increasing progressing your exercise protocol. Okay, so I would find aerobic exercises, they were saying 20 to 30 minutes minimum exercise, then you have to walk for track walking. So why I focused here is mainly track walking is most of the individuals, they don't go for gym. Okay, most of the individuals, they don't go for gyms. They want the cost effective equipment. So cost effective equipment is only a track walking. You walk, keep on walking around the tracks, around the roads, the streets, wherever you find a place to enough space to walk. You do a normal walking in a normal level. No need do on an elevated level also. Do a walking only, then automatically that becomes a aerobic exercise. If you want, you can do the treadmill based running, jogging, walking. So if you want to progress from track walking and walking, then you slowly progress to jogging, then you progress to running. So first, I would say you start with slow walking. So this recommendation is for a obese patient who wants to start on an exercise protocol. So first you start on a slow walking, then you gradually increase your speed to moderate high speed walking. Then you go for a start jogging. You do intermittent jogging. That is, we call it as fartlek training. So you do intermittent of walking, that is 2 minutes of walking, 2 minutes of jogging, 2 minutes of walking, 2 minutes of jogging. Then you slowly transform into a higher stage of exercise training. That is nothing but your jogging. At last, you can start running as well. So this is no need to directly start running. Running as a exercise protocol. So my doctor has told to run. So I would run 2 kilometers per day, 3 kilometers per day. There is no need to start. So start gradually, start slowly, and slowly progress such that you go to a stage of running. That's all. So that is my recommendation for your exercise aerobics. And when you progress to resistant exercise, we are having 3 days per week. So you do alternate ways. You do 1 day of aerobic, 1 day of resistance. And no need to do both at the same day. Why? Because our body tend to develop fatigue levels, and so better I would say do one day after, 1 day after. So we're having intensity of 1 RM. So find out the patient, find out for the patient's 1 RM how much is able to lift in one count itself. Then you go for a 10 to 20 reps, which is advisable 3 sets. 3 sets, and we can go for free weights. Free weight is nothing but you don't have a dumbbell. Okay, no problem. You don't need to buy a dumbbell also. You have a 1 liter water bottle, fill it with 1 liter of water. And if you want more weight, you fill the same water bottle with sand so that it becomes heavier. So it will correspond to 2 kgs or 3 kgs of your dumbbell size. So automatically you can start working on your free weights. Then we have to go for a body training. That is, without using any equipment, such as doing a squats, half squat, full squat. So without using any equipment, you can use your body weight as your training protocol for doing your resistant exercise. Okay, if you're not comfortable with your water bottle or any kind of resistance, try to use your body weight as a own exercise. Next is your flexibility exercise. So before you start your aerobic exercise or your resistance exercise, I would recommend you can go for a static stretching or a stretch, hold, relax method, nothing but your dynamic stretching. And no need to do ballistic stretching, and this should be a proper method. Why? Because this is a warm-up and a cool down exercise. So your flexibility exercises is going to do as a warm-up and cool down exercise. Directly, if you start walking or directly if you start do a resistant exercise, what happens? Your heart is not able to cope up. Why? Because heart is not ready to cope up with your function. So whenever you try to do a warm-up exercise, your heart is getting warmed up. That is slow increase in heart rate. There is no sudden increase in heart rate. Okay, so this protocol can be done for a normal obese patients also. This protocol can be done for your alcoholic fatty liver disease patient also, non-alcoholic fatty liver disease patient also. So combining this, so I would say first immediately start with diet modification, then directly go for your physical activity. Then you have to go for your interval. Then you have to go for interval training. Interval training in the sense we have to go for 3 days per week, and you're going to go for aerobic and resistance alternative. So these are my recommendations, and we have to do minimum of 30 to 40 minutes, even up to 1 hour. It's going to be a good effective exercise. Okay, coming to the summary, and NAFLD is a preventable disease, permanent cure. There is a stage of simple fatty liver, so you can still reverse back. So whoever is having more amount of junk food, they can still reverse back. Then we are having a liver disease consisting of 4 disease stages. So avoid junk food to maximum extent. Taking once in a month or twice, once in a week, advisable, okay, acceptable, but taking it as a daily extent, it's not at all advisable. Avoid junk food to a maximum extent, and one more important thing, avoid alcohol also. So we are going to have alcohol along with the fatty diet, again directly will end up in liver cirrhosis only. Have a habit of exercising daily. So have not only sedentariness. So some of them will say I'm physically active. That means they will be doing a lot of work in their work setup. So I'll be walking. I'm walking toward this my work setup. I'm standing and doing. I'm a housewife. I'm standing and doing all the works. But that doesn't come under exercise. So exercise is different. Your physical activity is different. So exercises you have to do on a particular time frame limit. I am going to walk 4 kilometers. I'm going to walk 2 kilometers in 30 minutes, 3 kilometers in 30 minutes. That is going to come under exercise, rather than I am going to walk same 3 kilometers or in a distance of span of 8 hours in an intermittent manner. So that comes under physical activity. Okay, so live have active life, both mentally as well as physically active. So reduce stress. So this generation stress is more common. Automatically we are going to have a good physical and active life. Okay, any questions and queries are welcome, and thank you Dr. Chandramohan sir, and for providing me this opportunity. And this is not only a new opportunity for me, because when I was a PG student, I already presented in this platform, so it is a good experience. Over
Thank
to
you, Sedhunivas sir. And we have few queries, and I will be reading it from our YouTube comment section.
Yes,
and
sir.
Before moving on to that, it was really a wonderful session, and you have covered that exercise prescription part also. That was very nice. And
Yes.
this is from, the question is from Sheikh Aisha. What is the clinical and cost effectiveness of exercise program for adults, young people, and children with the NAFLD compared with standard care?
Okay. Standard care is mostly we are going for a pharmacological treatment, and we are going to increase the physical activity. So most important exercise, whatever exercise we are going to do, as a result, what will happen is your exercise tends to make your muscles fit, muscles in a good state of support. And whenever we are going to move a muscle, automatically we are moving a fat, we are mobilizing the fat. So we are having so many layers. So starting from skin, we are having skin. Next layer is your fascia, adipose tissue. Next layer is your fascia. Next layer is your muscle. The last layer is your bone. So whenever we do exercise, So automatically we are trying to mobilize the fat. By moving the muscle, we are mobilizing the fat which is present between your skin and your bone. Automatically we are doing this. So whatever exercise is going to be a very cost-effective tool. So you need not spend on medications. You just do a reduction in a fatty diet, do more of exercises. Automatically that is going to benefit in a longer. So it's not going to benefit in a shorter run. So yeah, I've done 1 month. So I want to check my levels. So that won't provide any change. So you have to do more than a year so that there will be changes in your levels start happening.
The next question is from Guram Vidyasagar.
Yes.
What type of measures you would advise for a person who has got busy work schedule and can't do dieting as well as preventing NAFL?
Dieting still they can do. They have to modify they have to control their eating habits. They have to modify their things. And there is a person who is going to be in a busy schedule. I feel he's going to have he should have a good sleep as well. So there is no busy schedule. Even the people who are going to have a busy, they are going to at least, I would recommend half an hour in your busy schedule. I would recommend you to start doing your exercises so that you can cover up. So busy schedule is nothing but maybe you may be a sedentary person as well, but in your busy schedule you might be getting some breaks. In the breaks, you're trying to do a 10 squat, 20 squat, 30 squat. Automatically you're moving your muscle, you're reducing your fat buildup. So automatically, whenever you try to get a break, tend to do an exercise. So that will become your intermittent exercise program as well.
The participants in Zoom, do you have any questions? Any of you would like to ask questions to our resource person?
Good evening, sir. May I go?
Yes, sir. Kindly introduce yourself and then please open the cam.
This is Manoj, a physiotherapist.
Yes,
so my basic question is, the last slide that you put up for exercise prescription for non-fatty disorder.
Yes, sir.
If you want to mobilize fat under exercise alone, either American Heart Association or ACSM focuses on frequency of at least 5 days per week. But yours is only 3 days per week. Is it right so to mobilize fat to that much extent to get a good result regarding that?
Okay, got your question, sir. And so I have said as 3 days per week, that is aerobic exercise 3 days, resistant exercise of 3 days. So it automatically comes to 6 days per week.
No problem with the resistant exercise, sir. If I'm going with the aerobic exercise alone.
Yes. Yes. Okay, got your question. So if you're going to do only your aerobic exercise, you don't have any equipments to do, or you're not in a mood to do of your any kind of resistant exercise, then you can go for 6 days per week of aerobic exercise. If you want to have a variety, so for example, if the patient is going to do a walking alone, what will happen is, so the 1 or 2 days he will try to go for a walking, then he might lose the interest. So in order to avoid lose the interest, as well as strengthening the muscles. For example, when we do a walking, so what happens is we are utilizing the joint range, we are utilizing the muscles to a certain extent. We are not utilizing our muscles and joint to a major extent. But when we do a resistant exercise, for example, you are going to do only simple knee extension, quadriceps knee extension. What happens? We are going to start from less than 90 degree to 0 degree. So extension is from greater than 90 degree to 0 degree. But when we do a walking, what happens? We are reducing. That means we are utilizing only the extension of 30 to 45 degree only from to 0 degree. That means you are underutilizing your muscle. So those who want variety, or those who want variety and I need not boring of exercises, I would say you can go for 3 days a week. If you are well able to exercise, and if you are well able to exercise, like without any fatigue, you are taking adequate rest, I would say that you can do aerobic and resistance in 6 days also. If you are able to do. If you're not able to do, I would recommend 3 days a week, 3 plus 3 do. Otherwise, if you're able to still concentrate, if you want to do only your aerobic or a resistant exercise, go for 6 days per week.
Thank you so much. But will the increase in the range of motion of using a particular muscle will have an impact on the metabolism of fat in our body by means of reduction? Will we go into the zone in which we are going to break down the fat and it is going to convert it into energy?
Yes, doing an exercise and doing an exercise, and we are going to do the fuller extent is mainly important, sir. Not only doing increasing a heart rate, increasing our blood pressure, that doesn't help at all. So we have to do to a fuller extent so that we are going to build up the muscle. When we do an aerobic exercise, we are not going to build up any muscle. We are going to build up a muscle to a very less extent. When you do walking, I am not going to build up a muscle, but you are going to maintain the muscle. But when we do a resistance exercise, I'm going to build up a muscle such that my fat deposition, my extent of fat deposition is getting reduced to a greater extent.
So what are the variables that you will be focusing upon in this patient, sir? Since you yourself have told it is a hidden disease, only by means of mass screening or the person who is going for screening alone will come to know across that he is having a fatty liver.
Yes.
So how do you predict the variables that you are going to work it upon?
Okay, so whenever you see a patient with obesity condition, automatically we have to recommend these tests, lipid profile and your ultrasound scan abdomen, to ensure that you don't have the disease. You're having only the pure obesity. If you're having obesity and you're having a fatty liver disease, you have to strictly control your diet and we have to strictly focus on the exercise protocols.
Yes, sir. But for obese people, if you are sticking on with the strength training, in terms of a field approach, I have found out many difficulties for putting them into strength training protocols. Like as you said, we are going for muscle building. The initial problem is to reduce the weight. So we tend to prefer aerobic exercises for initial with resistance training in future. Thank you so much for your answers.
Thank you, sir. It was a nice discussion. And there is another question from Ravindra Reddy. So what is your opinion on the relationship between keto diet and NAFLD?
Keto diet, not much idea, not that much idea. So I have to more focus. Will post in your comment sections.
Yes, that's a nutrition part. As a physiotherapist, we mostly concentrate on the exercise part. And there is another question from Chitra Swaminathan. My patient age is 45 years and non-alcoholic with triglycerides 460 and type 2 diabetes LDL 70. So kindly give your opinion for this patient.
So the levels are less only, ma'am. So their patient, the triglycerides are going to be less than 140, and you're going to have a LDL is also going to be less. We have to concentrate on more increasing the HDL cholesterol. So if they concentrate more, they're going to take more amount of good fats. Automatically, they're going to have a good lifestyle. Hello.
Okay. Yeah, Zoom participants, do you have any other questions? I request you to be with us. There are a few questions which moved up. I couldn't access. Can you rewrite the questions in the comment section, please? So meantime, I would like to take questions from Zoom meeting. There was a question I remember, sir. It is from one of our friends, Dr. Prem Kumar.
Yes.
He was asking that how can you find fatty liver disease just by observation, not by going for screening?
Yes, by doing a physiotherapy evaluation, we can still find out, sir. By doing a waist circumference, and we are going to estimate the person is a candidate of central abdominal obesity. This person usually tends to have a NAFLD. That is a confirmed condition. If you're having a abdominal obesity, and if you're having a increased waist circumference, you're having a skin fold thickness, that is our non-invasive, our part. So then we can recommend for a blood lipid profile or an ultrasound scan for an exact confirmation.
Thank you, sir. And
hello, sir.
Yes, sir.
Yes, sir.
So good evening,
Please,
sir. This is Ravindra Reddy.
On the cam, please. Is it possible?
No, sir. No. Actually, I'm right now out of station.
Yeah, please carry on.
I have few questions actually.
Yes, sir.
In your talk, it was a great talk actually, sir. It was like a new idea about what we regularly we don't see this thing in all patients. We don't screen these things, but as a
Yes.
baseline assessment, we go with LDL, HDL. But many patients don't have any idea about how this is going to affect the liver and all. But whatever the information you have given, it is actually great, and it will really we will represent that in our screening also, sir. Surely.
Sure, yes, sir. Thank you.
Okay. Actually, you said that in steatohepatitis, it is irreversible in your presentation. By what way you're saying it is irreversible? Because of fat deposition, it is going to cause a systemic inflammation in the liver, causing damage of the hepatocytes. But if we do physical activity, it generally it causes a reversibility, to my opinion. So there is reversible option possibility is there, sir.
Possible, yes, sir. It's possible only with medications. Medications also additionally you have to take along with your physical activity and exercise. You don't take any medication, but concentrate on exercise, or you don't do exercise, but you still concentrate only on medication. Automatically, it's going to be irreversible. So you have to do a combination of both exercise as well as your medications in the stages of NASH. For NAFLD patients, only you do exercise alone, that is fine, because there is no inflammation process.
So the overall talk is about a predisposition of obesity towards NAFLD, right, sir?
Yes, sir.
So if we prevent obesity, we can prevent this disease.
Confirm, yes. So automatically, if you avoid obesity, there is no fat deposition in your skin. Automatically, there is no fat deposition in your organs as well. There is no fat deposition in your arteries as well. So simple thing is, first prevent obesity. Automatically, every other diseases are going to be prevented.
Oh, thank you, sir. Thank you for that. I have one more question. What is your comment on liver rehabilitation, sir?
Liver rehabilitation, as of now, only pulmonary rehabilitation and cardiac rehabilitation is coming, sir, and still we have to concentrate. So this I want to create an awareness. So first, when just concentrating on the exercise protocols, that will come under liver rehabilitation, sir. Concentrating on aerobic and resistant exercise protocols itself, that will come under liver rehabilitation.
Okay, sir. Thank you. Thank you so much.
Okay.
Hello, sir.
Yes, sir. Yes, ma'am.
Sir, what about the visceral manipulation in this condition?
No idea, ma'am. No idea. Right.
Hello, sir. Hello, sir.
Yes. Yes.
Sir, myself, Dr. Shah, physiotherapist.
Yes,
From
sir.
physiotherapy point of view, if the patient come in NAFLD in early stage, so without any ultrasound, without any USG, without any MRI, how can we detect this? It is NAFLD, or how can we differentiate it is NAFLD or ascites or NAFLD or any other liver disease? Sir, how can we detect, sir?
Yes, sir. So that's what I was saying. First, you as a physiotherapist, you do your we can do our assessment. Then when it's confirmed, like patient is having more amount of fat deposits, then we can go for a gold standard diagnosis. That is a ultrasound scan. Then we can go for a liver biopsy, sir. So as a physiotherapist, we can first find out whether patient is having a obesity, amount of fat deposition. If that is showing abnormal values, then you can go for all these diagnosis, exact diagnosis.
Okay, sir.
There is a question from Savita T. She was asking for protocol for stage 3 or 4. How much exercise can be done with symptoms?
Okay. So whenever the patient goes for a stage 3 or a stage 4, so what happens is the patient is already deconditioned. Patient is unable to go for exercise, doing the exercise to the maximum extent. So we have to go for lesser exercise protocols. That is, they have to walk only for. So we are having a fit protocol. So we are having a fit protocol for frequency, intensity type, time type, which I have already discussed. So when these patients are going for a stage 3 or like last stages, what we have to do is first we have to go for frequency we have to increase. For example, they're going to do exercise. So I have recommended like one day you do exercise, 3 days a week, 3 days a week you do exercise. That is only once you do the exercise I've recommended. But when these patients, what we have to do is we have to increase the frequency such that they have to do twice a day. So they have to do morning, evening, they have to do, but less amount. That is less time. For example, they're going to do for 40 minutes. These patients has to do only for 20 minutes or 30 minutes. So as they build up their level of exercise capacity, then they can go for the normal training protocols. But as of now, I feel these patients are a little irreversible stage only, but they can still sustain their life and move on their life by doing these exercise protocols.
Yes, sir. There is another one more question from our Zoom participant, and it is related to nutrition. Can intermittent fasting helps in this kind of patients?
No, intermittent fasting generally tends to increase your blood levels, blood glucose levels, and your fat levels only. Why? Because these fat levels, whenever we do intermittent fasting, so your body accepts whatever you take, whatever we take the next diet, whatever the diet we take next up. So that is completely utilized. So automatically, I would say it's not good. It's not to go for intermittent fasting. You reduce your fatty diet and you can reduce your go for a nutritious diet. Automatically, that will help you. No need to fast.
Okay, sir. Thank you. Any other questions from Zoom? So that if there is any, I request you to discuss now.
Actually,
Any
there are
other
more, sorry for interruption, sir. Actually, there is more evidence on intermittent fasting plus keto diet on weight loss.
Okay. But whatever food we tend to take during after the intermittent fasting, that is completely utilized. Correct?
I definitely agree with you, sir.
Yes. So better if you take a good nutritious diet, maybe it will help you much.
Yeah, but the contradictory statement in that is how keto diet, which is a high fat content, is going to cause this how it is going to affect this diseases, liver diseases actually, because it is actually we know, but from your talk that obesity is actually one of the causative risk factor for causing non-alcoholic fatty liver disease. But there are more evidence showing that keto diet, which is a high fat content, along with that intermittent fasting, has shown great results in reducing the weight. And that is a direct representation of what obesity will not be present in that kind of cases. So, so there is a mixed kind of.
There will be always a mixed kind of opinions, but I feel still intermittent fasting is tend to be avoided. We take a full diet also that is good of nutritious. There is no need to fast at all. There is no need to go for keto diet or nothing. Just go for a nutritious diet, which is less in fat, less in carbohydrates, more in protein, and automatically you're going to go for a good diet, good nutrition.
Yes, sir. Thank you.
Excuse
Thank
me, sir.
you. Yes, there is another one more question from Priyadarshini in Zoom meeting. Insomnia cause any liver diseases specifically?
Insomnia. Okay. So whenever we are having insomnia, there is a loss of an appetite. So there is a change in your eating habits. So you tend to eat in untimes. Your overall metabolism, overall sleep factor. So it's going to change automatically. These patients are prone to NAFLD.
Yes, sir. Somebody was there to ask some questions. May I know who's that?
Hello, sir.
Yes.
Sir, myself is Chandra. I'm having on a suggestion only because they asked about keto diet.
Yes, ma'am. Welcome.
So for them only I'm saying keto diet, they're having so much of evidence is there, but that giving a more complication after the this exercise training, because metabolic rate is one of the matter.
Okay.
So that will be getting affected in advanced stages only, not early stages. So there will be the evidence for a weight loss only, not for a metabolic rate. So that will be giving so much complications, consequence will be there in the later stages.
Okay, acceptable.
Thank you for the information. And there are no questions in YouTube. And so last chance to the Zoom meeting persons. Is there any? We will wind up. Okay, we have got a question that 9 weeks of pregnant women identify as a fatty liver. How can we treat them?
Okay, okay, no idea, ma'am. But I would say first let them complete the pregnancy with less amount of complications. Then they can go for an exercise training and reduce your fatty content, and automatically they can go for there will be reduction in the fatty levels.
Yes, yes, sir. Thank you. It was really a wonderful session. Okay, very elaborately. I thought that we will finish within 60 to 75 minutes, but it was extensive. And before we move on, one last question from Benazir Hassan. Is it AFLD disease irreversible when patient stops alcoholism?
Okay, that depends. That depends on how much years they have been drinking. So how much years they have been drinking. So I would say depends. So how much level? For example, if they like this is like a smoking. So 1 cigarette per day or 10 cigarettes per day depends, right? Same thing.
Okay, sir. Thank you. Thank you so much. And we have questions coming. I request our participants to put your questions in our you can send it to our WhatsApp, so we will post the answer in our WhatsApp group itself. And thanks for taking so much of time preparing for this webinar. And I would like to thank Mrs. Duna, ma'am. First of all, wish you a very happy wedding, and thanks for joining with us today.
Thank you so much, sir.
Helping us to connect with YouTube. And also I would thank Dr. Prabhu Shankar for helping us here in this end. And once again, thank you, Dr. Sedhunivas, for the wonderful session. And there is an announcement that we are going to have the next webinar on cardio rehab, that is on talk. So surely we will be sharing the details sooner. And after that, in the August first week, an ortho topic is there. So we request you to kindly stay with us, and your certificates will be sent within 2 weeks. Thank you all. Thank you, Duna madam. Thank you,
sir. Thank you,
Sedhu
everyone.
sir, and thank you,
Thank you,
Prabhu
sir.
sir. Bye bye. Good night all.
Thank you.